The broadcast is now starting. All attendees are in listen-only mode.
All right, good afternoon to all our listeners out there today. We're going to have a little discussion this afternoon about hyperkalemia and go through an introduction to hyperkalemia. Sitting in the booth with me today, we've got Nat Cram, who is our EMS fellow, as well as Christine Hardy, one of our pre-hospital specialists. So we are going to get started. A couple of housekeeping things that we need to go through. If you are new to this format, in the background what you'll see is a PowerPoint presentation, and then you'll hear us talk through the next hour on that, and you'll get a bit of background delivered from that. The other thing you should see is a control panel, and it'll have a question or a chat box as well as a hand icon. Throughout this presentation, if you would like to ask a question, feel free to do so by typing in your question, and that will give us the ability to have a look at it. We'll read those questions and answer them throughout the presentation. If you have a microphone with your computer and you want to ask a question live at the end of the presentation, just click on that hand icon and that'll show us that you have a question, and then we can unmute your microphone so that you can ask the questions. I will now hand over this presentation to Nat and Christine, and they will take you through an introduction to hyperkalemia.
Great. Thank you, Mike. Happy Paramedic Services Week to everyone joining us today, and we appreciate you spending the hour with us. Let's start off. Looking at the objectives for our webinar. On completion of our webinar, the paramedic will recall the basic pathophysiology of hyperkalemia, explain how illness, injuries, and other factors lead to hyperkalemia, explain the complications associated, and recognize hyperkalemia in the pre-hospital setting using simulated patient care scenarios. So we'll start off by talking about what exactly hyperkalemia is.
Hi everyone, it's Nat here. Happy Paramedic Services Week. It's a pleasure to spend the hour with you. So I'm going to give you a brief background on sort of basic pathophysiology related to hyperkalemia and sort of explain why it's important and explain why it can cause trouble in some of our patients. So hyperkalemia at a very basic level is an elevated serum potassium level. General sort of normal lab values would be between 3.5 and 5. And when patients start getting into trouble, some of the patients that we would see in the emerge department that are having some of the arrhythmias and complications that we'll be discussing a little bit later, they can have values sort of in the 7 to 9 region. And so I guess the big question is, why is potassium important? Well, it's one of our body's important electrolytes, and it's necessary to maintain normal cardiac and neuromuscular function. So if you look sort of at the cell, and you may remember this from sort of other schooling in the past, there's sort of ions in the cell and outside of the cell, and potassium is the major intracellular positively charged electrolyte. And there's a lot of potassium inside cells and very little outside of the cell. So in terms of concentration, there's sort of 140 milliequivalents inside compared to 4 milliequivalents on the outside. And this difference in potassium concentration becomes really important. And this difference from high to low creates this electrochemical gradient. And in a really simple way, a good way to think about this is sort of harnessing electricity from a dam. And if you think that, generating hydro as water's flowing from areas of sort of high elevation and to lower elevation, you're able to get that energy and sort of use that. In the same sense, the cell is able to sort of use that difference in potassium gradients and other electrolytes and do other work within the cell. So it's really important to keep that difference of high on the inside and low on the outside. So where do we find potassium in our body? Most of it, as I said, 98% is actually inside the cells in the intracellular fluid. And most of the potassium is found in our skeletal muscles, liver, and red blood cells. And that will, again, become important when we talk about causes of hyperkalemia, because a number of those causes are related when there's been damage to those skeletal muscle cells, red blood cells, in the body. So the 2% of the body's potassium that's outside of the cell is actually the potassium that's really important for our cardiac and neuromuscular function. And so this is the level that we measure when we take a serum potassium reading. Now, unfortunately, in the field, obviously you guys don't have access to that potassium level, but that's actually the level that we're getting sort of in the emerge department. So we're only really capturing a very, very small amount of the body's total body potassium, but that's the most important part. So where do we get potassium? How do we get rid of potassium in our body? Potassium primarily comes from dietary sources and is absorbed by the intestine. In terms of how our bodies get rid of potassium, the kidneys play sort of the most important role. So most of our potassium is excreted in the urine when our kidneys are working properly. And there's sort of numerous mechanisms that if we have a high potassium load in the diet for whatever reason, that can then excrete a proportionate amount. There are also small amounts that are eliminated via feces and sweat. So what sort of things cause hyperkalemia? Probably the most common that we see and the most common that you guys will see is renal failure. And that can be renal failure either in an acute setting or in a chronic setting. So the chronic setting, we sort of think of patients that have had kidney failure for years, patients that may be on dialysis, but there are also acute kidney injury that can cause hyperkalemia. And that's just the fact that the kidneys then aren't able to sort of adjust those levels and excrete potassium appropriately. So another cause of hyperkalemia is cell death. As I mentioned previously, most of the potassium actually lives inside of the cells. And so when we have crush injuries, large burns, rhabdomyolysis or tumor lysis syndrome, these are all different things where when the cells die, sort of the intracellular contents are released into the bloodstream in the serum. So when you have cell death, that very sort of high potassium concentration from inside the cell is now released and is contributing to that sort of that extracellular or that serum potassium level. And that's the level that sort of plays the important role in sort of the cardiac and neuromuscular functions in our body. So certain drugs can also cause hyperkalemia. There's a number of potassium-sparing diuretics. One that you're probably familiar with, seen on patient lists, would be spironolactone. Amiloride is another one. NSAIDs can actually cause hyperkalemia, as can ACE inhibitors and ARBs. And that's because they all affect kidney function. Hyperkalemia can also be seen in the setting of acute digitalis toxicity. So patients that are taking digoxin and may be unwell and their digoxin levels may be getting high and in the toxic range. Acidosis is a final common cause of hyperkalemia, and that can be seen in DKA, in Addison's disease, and adrenal insufficiency. So as I said, the most common cause of hyperkalemia that you'll probably see will be in your chronic kidney disease or dialysis patients, but for patients that may have other risk factors, certainly something to keep in mind. So how do we know and how can you know if a patient is hyperkalemic? As I said, in hospital, we're fortunate and we have the benefit of being able to get a gas and blood work to tell us that. In the field, though, you can be suspicious if you have sort of the history that we just talked about, but things that you might see are ECG changes. And there's a lot of ECG changes that can be associated with hyperkalemia. One of the first and sort of most commonly thought of changes is peaked and pointy T waves, and we'll have a picture of that coming up next. You also start to see changes in the conduction, in cardiac conduction. So the PR interval can start to get longer, and then you actually see the P wave flatten, and eventually you lose the P wave. Then typically you'll see sort of the QRS start to widen out, and eventually it forms into sort of this sine wave pattern. And again, we'll have a good picture of that coming up to show you. Eventually you start to see rhythm changes, and those can include ventricular tachycardia and fibrillation, as well as PEA and asystole. So kind of looking at that list, there's certainly a lot of different ECG changes associated with with hyperkalemia. So something to be thinking about. All right, so here's a nice picture of some pointed peaked T waves. As you can see, those T waves are almost as tall as the QRS complex, and they looked quite pointy. Now, someone once told me, you know, what's a peaked T wave or a pointy T wave versus a normal T wave? And if it looks uncomfortable to sit on, then that's kind of a good starting place. So this is sort of a good classic example of peak T waves. All right, again, similar compared to the last slide. These T waves are certainly even taller than in the last picture that you saw, and much pointier. Here the QRS is also starting to widen out a little bit. So this is something else that you might commonly see in a patient with hyperkalemia. All right, so this is sort of that sine wave pattern that can be associated with severe hyperkalemia. You can see that QRS complex is getting really, really wide. You don't really see any P waves marching through there at all. And even beyond this, sometimes that curve can even become smoother. And so at this point, you're really starting to worry about your patient. They're pretty sick with their hyperkalemia if this is what their ECG is looking like.
I don't know if you've ever heard the people talk about how to figure out the ECG for high potassium, but one thing that's described is the whole fishhook idea on either side of the QRS complex. And basically they say if you put a fishhook in the top of the T wave and a fishhook in the P wave and then start pulling them apart, you start to see what happens as potassium gets high. So the first thing you see is that nice big peak T wave. Then you start to see it start to lengthen out, the prolonging of the PR complex. And then as you get further and further out, it starts to get that sine wave pattern.
All right, so when we look at treating hyperkalemia, we sort of have a few immediate goals. The first goal is to stabilize the cardiac membrane, because where patients run into trouble and get really sick with this is when they have arrhythmias. Our second goal is to shift that extracellular potassium, so that potassium outside of the cells, we want to shift it back into the cells, because once it's back in the cells, it doesn't have the same effect on our cardiac conduction system. And our third goal is to remove potassium from the body. So going through each of those, how do we stabilize the cardiac membrane? The first thing that we do is to give calcium gluconate or calcium chloride, and that helps to decrease the excitability of the cardiac cells and sort of decreases the likelihood of arrhythmia. And so typically in the emerge department, if we see somebody that's coming in with hyperkalemia, calcium is actually the first thing that we want to give them. While it's important to shift that potassium back into the cells and eventually remove it, the first thing that we want to do is sort of stabilize and prevent any dysrhythmia. So calcium increases the cardiac conduction speed, and it narrows that QRS complex back as it's starting to widen. A good thing to remember while we're treating with calcium, it's actually not lowering potassium levels. So it's stabilizing, but it's not lowering. So the second thing that we want to do is shift that extracellular potassium back into the cells where we would like it and where it can't cause as much trouble. So there's a few ways that we can do that. One is giving beta-2 adrenergic agonists, such as Ventolin or salbutamol, and that's going to push that potassium back into the cells. In hospital, we typically give insulin and glucose, and occasionally we'll give bicarb. Now, a quick note about bicarb so bicarb doesn't work all that well or all that quickly. So a number of studies have been done, and in terms of the evidence for it actually lowering potassium levels, ultimately it does so pretty minimally, and it's been found that bicarb is most effective if it's given for patients that have hyperkalemia because they have a metabolic acidosis. So it's only useful in a small number of circumstances. The other thing is it's usually given with a significant amount of fluid. So typically we'll put 3 amps of bicarb in a liter of fluid, but a lot of patients that that we would be treating with hyperkalemia, such as our dialysis patients, are already fluid overloaded, and so the extra volume is not helpful. So bicarb is something that we consider, not something though that at this point we're advocating for in the pre-hospital setting because of those other considerations and complications. All right, so once we've stabilized the cardiac membrane and we've shifted potassium back into the cells, ultimately, to fix this problem, we need to remove potassium from the body. And there's a few ways that we can do this, sort of depending on the cause of the hyperkalemia. So often diuretics, such as Lasix, can be used to sort of promote the kidneys to excrete potassium. Something else that is occasionally used are potassium-binding resins, such as Kayexlate. Something important to remember, these medications work slowly over many hours and aren't really part of our acute management of hyperkalemia. And so while they can be helpful in the long run, especially with the Kayexlate, or potassium-binding resins, this is another medication that also can have some complications. It's been shown in a few studies that it can actually cause sort of necrosis of the gut and other problems. And so this is sort of something that we consider in hospital. But again, the research is always changing, and we try and keep up with that. Sort of the most definitive way to remove potassium from the body is hemodialysis, and that's sort of can definitively remove the potassium, the extracellular potassium, from the bloodstream. And often it is dialysis patients that have either missed their treatments, and this is part of the problem. But in an unstable patient that is sort of refractory to our other treatments, hemodialysis is ultimately the definitive management.
Great, thank you very much, Nat. We're going to start off with one case discussion, and hopefully you can help us walk our way through it and kind of explain what we're seeing and why we're seeing the things as we go along. So let's say that we're called to a residence for a 67-year-old who's feeling unwell. When we arrive, we observe a female patient who opens her eyes when spoken to and states she just feels really tired. Upon assessment, her airway is patent, breathing spontaneously and adequately. And as we assess the pulse, we find an absent radial pulse and a very slow carotid pulse when we complete that initial assessment. Upon further questioning, we determine that the patient regularly attends dialysis appointments, but in the last couple days, her car's broken down, and she's missed one dialysis appointment 2 days ago. So she's been feeling unwell since that missed dialysis appointment. You can see her allergy and medications there. Pertinent past medical history is the renal dysfunction with the history of dialysis. She's a non-insulin dependent diabetic and has a history of hypertension. She ate this morning and again describes increasing weakness with nausea since approximately 2 days ago. So you can see her vital signs in front of you. Her heart rate's 57, is regular. Blood pressure is a little bit low, 90/60. Respiratory rate is regular, satting 99%. We have an end tidal in place as well, 45. And we assess her blood glucose level and find it to be 24 millimoles. So upon performing a 12-lead ECG, which would be something most medics would do in this situation, this is what we see. So if you recall from Nat's description of ECG changes associated with hyperkalemia, we can see that we have the tall peaked T waves and definitely would not want to sit on those. So in this instance, we might want to start thinking in the direction, well, the patient has a history of renal insufficiency, has missed dialysis appointments, is feeling unwell, showing some signs and symptoms of hyperkalemia. With the 12-lead evidence in front of us, this may lead us in a direction to consider hyperkalemia as a possible diagnosis. So in terms of pre-hospital recognition of hyperkalemia, let's consider the patients that are most at risk. Again, they're the chronic kidney disease patients who are on hemodialysis that may have missed treatments. Other patients that may present to us would be crush injuries. And again, like Nat said, patients with an acid-base disturbance, DKA, prolonged status seizures, major burns. Some patients who have experienced prolonged immobilization. Signs and symptoms would be CNS symptoms such as muscle twitching, cramps, GI issues, diarrhea, nausea, vomiting. And for us in the pre-hospital setting, some of these are so obscure. However, if taking a good, thorough history and associating the signs and symptoms that the patient's complaining of, as well as with the ECG and the history, performing the 12-lead ECG, seeing the bradycardia, possibly the peak T waves, we can hopefully come to somewhat of a decision of what's going on with the patient. So let's start off with a couple of questions. So how do we actually define a peaked T wave?
Just to jump in here, Christine, that actually times out very well with one of the first questions that we've been emailed in, which is...
So the question that was emailed in was, I was taught that generally peak T waves would qualify as anything larger than 2/3 the height of the airwave. Is this true? Now, this is beautiful because this is almost an intro into your slide here.
Okay, so some information that we've pulled from the MAC committee is that a T wave that appears peaked and is about approximately 1/3 the height of the R wave, is greater than 1/3 the height of the R wave associated with the history, we would consider as a peaked T wave. They're caused by a change in the resting membrane potential due to the increased potassium in the extracellular fluid. It leads to the early excitatory reaction, causing the peak T waves to become, well, peaked. Something to bear in mind is that not all patients suffering hyperkalemia will have significant ECG changes. And you can't necessarily correlate the degree of hyperkalemia with ECG findings. Can you explain that a little bit further, Nat?
I mean, I think what you said is exactly right. Well, we sort of went through all the different things that can happen with hyperkalemia. It's not like we can say, at a potassium of 6, we see peak T waves, and then at a potassium of 6.5, we see something else. It's different for every patient. So the history and sort of knowing what else is going on with the patient is really, really important, because you may have peaked T waves and could have a potassium of 5.5, or you could have peak T waves and have a potassium of 7. Conversely, it's important that if you have a normal looking ECG, that also doesn't mean that you don't have hyperkalemia. So the ECG is sort of like a clue. It plays into everything else that's going on with the patient, but we can't sort of hang our hats on the ECG.
Good, thank you. So discussing a little bit further the sine wave, what exactly is a sine wave? Nat, you did a great job of explaining that. Something that we just maybe learned in school and haven't discussed very much as paramedics. So basically it's a bradycardia, and like Mike said, a widening complex, like with the fish hooks was a great analogy. So the combination of the bradycardia and the sine wave is very concerning, and it hints at impeding cardiovascular collapse. So if we're seeing in the field, we have the history of the patient with the chronic renal failure and missed dialysis appointments, or whatever that big story is. Consider that a wide, irregular, bizarre-looking ECG. If you're unable to figure out what that is, because in all honesty, it's not necessarily going to present like you're seeing on the screen, consider with that history that the patient's suffering the hyperkalemia, and that there's potential here for cardiovascular collapse. And likely quickly. So very commonly, a sine wave precedes ventricular fibrillation and asystole. If we're seeing that in the pre-hospital setting, it would be a good indication of a time to put on your defibrillator pads and consider reassessing the patient promptly and regularly. So again, we kind of alluded to the fact, if we have a patient with risk factors or a good history that indicates they may be at risk for hyperkalemia, we perform a 12-lead ECG in the field. Can we actually rule hyperkalemia out as a cause of the patient's signs and symptoms? And the answer is no. So wait a minute, what you're seeing there is actually not a normal ECG. This is the one we would be seeing. So we just want to make sure you're paying attention there. So again, there's no definite correlation between the level of hyperkalemia and the development of the ECG changes. So this ECG in a patient with the history does not rule it out. And this becomes important because if we have a patient who ends up in a bad state, who's suffering hyperkalemia, they're relatively not going to do well with the traditional resuscitation measures taken place in the field, and sometimes need some additional steps taken that could lead us to a more successful resuscitation, and we'll talk about that in a minute. So given that hyperkalemia is seemingly not uncommon, considering the rates of renal disease in Canada, can obviously be potentially life-threatening. There is something that paramedics can do in the pre-hospital field to assist in stabilizing these patients. So what you see in front of you there is a dialysis machine to get you, again, thinking that the renal patients are the ones at most risk. And we are going to be adding an additional directive to the advanced care patient care standards that address these patients specifically. So in the fall, we will be introducing a hyperkalemia medical directive. I'm sure most of you have probably already heard that. And the directive itself will address the high-risk patients who are either in cardiac arrest or in a pre-arrest state. So we're not going to go through the directive here today. It's just an introduction, basically, to get you thinking, to get you considering the patients that would be at high risk, and looking at how we're going to adjust our assessments and our history taking and the way we treat these patients in the future. So we, again, talked about the high-risk patients, and we won't review that section again. Actually, in the last 20 years, 1 in 10 Canadians have been diagnosed with kidney disease, and it's been increasing. So the addition of this directive to our level of care is extremely beneficial. The goals of pre-hospital treatment. Now, we discussed the goals of in-hospital treatment earlier, and Nat had alluded to the fact that we're not going to really be able to remove the potassium from the patient's body, but the things we will do in the field is recognize the hyperkalemia or the possibility the patient's suffering hyperkalemia. We will have the ability to stabilize that cardiac cell membrane, and we will also have the ability to redistribute the extracellular potassium back into the cells. So basically, we're going to recognize it, stabilize the cell, and we're going to put it back in the cells, and hopefully get the patient to the emergency room quickly with a reasonable differential diagnosis and make a difference for the patient. So again, this will be coming to our 2015-2016 research, and what you will see, advanced care paramedics will be administering calcium gluconate and salbutamol. So looking back into what Nat said, calcium gluconate is how we are going to stabilize the cell, and we're going to attempt to redistribute the potassium back into the cell with the use of salbutamol. So it should be an interesting research this year, and very exciting to introduce it. It's a change to our practice, the change in the way that we actually treat our patients and assess them overall. As I said earlier, in cases of cardiac arrest due to hyperkalemia, we should be patching early when we're starting to recognize that this may be a hyperkalemia patient, because our early routine treatments and the common treatments that we do in the pre-hospital field for cardiac arrest management may not necessarily respond. The patient may not necessarily respond very well until we do administer the calcium gluconate. So keep your questions coming. We've had a couple great ones come in. I know this is a lot of information. That's why we're not fully introducing the directive to you now and changing how we do everything. But we just want to get the recognition piece out first and the pathophysiology. And please keep your questions coming. Let's look at a second case discussion. Probably a fairly rare case discussion, but all the same. Let's say we respond to a farm for a 65-year-old male He was found trapped under a large bale of hay. When we get there, we observe the patient, obviously with the bale of hay on his lower limbs, and we notice that it's below the pelvis. So he has fluctuating level of consciousness as we're attempting to speak to him. His airway's patent, he's breathing rapidly, in obvious pain, and has his radial pulse is present. As we do our full trauma assessment on this patient, we notice that the upper body is unremarkable. With the assistance of the fire department, we're able to remove the bale of hay that's atop the patient, and we start to prepare equipment, obviously, and our stretcher for rapid transport. So he has some loss of feeling in the lower limbs with severe pain, has an allergy to morphine. Our story goes that the patient's son says he returned home from school and found his father laying in the barn with the bale of hay on him. He says that he last saw him working in the barn about 6 o'clock this morning, and when he came home from school, so we'll assume that's approximately 3 or 4 o'clock in the afternoon, he found his father like this with the bale of hay. So we're asking the question, are you thinking about hyperkalemia at this point? And we hope you are. If you recall, one of the risk factors for hyperkalemia, and one we should recognize, is that a prolonged crush injury is associated with the progression of hyperkalemia. So again, just to reiterate, looking at our high-risk patients, this would be one of them, that he's had a prolonged crush injury. It appears as if he maybe has laid there for possibly 6 to 8 hours with this large bale of hay across his lower limbs. Is he in a pre-arrest or an arrest state? I mean, that would be specific to whatever scenario you go to. But let's discuss quickly, obviously we can recognize someone who is in cardiac arrest, but how do we define a pre-arrest state? And I think different medics would possibly define this differently, but we do have some direction in this medical directive when we get to the point of using it. So we're looking at patients who are hypotensive, have an altered level of consciousness, are experiencing symptomatic bradycardia. So we'll use those signs and symptoms for our purposes of defining a pre-arrest state. So how does this change what we do? Significantly, actually, because we recognize that the bale of hay on this patient is possibly a high risk for development of hyperkalemia. And if we recognized the pre-arrest state, the hypotension, the altered level of consciousness, then we would actually be required to do a 12-lead ECG on this patient. It's not necessarily something we would typically do pre this new directive. However, because we're considering hyperkalemia as a cause of his pre-arrest state, we would do the 12-lead. If we found that the 12-lead showed signs that the patient had hyperkalemia, like the signs we discussed before, then we're going to proceed forward with this medical directive. We'll be patching to our base hospital physician, and we'll be getting direction on how to treat him appropriately. So again, when we enter research, these are the types of changes in practice that we're going to introduce to you, and we're going to practice and then hopefully lead us down the road of excellent treatment of these patients. We're really looking forward to this year's research to introduce that. So some further strategies, again, just as a review, be suspicious and identify your patients at risk for hyperkalemia. A good thorough history, even in the sense of, even if we're sensing that the patient is a load and go patient or is critical and we want to get them out to our truck, get a thorough history and perform all necessary assessments. An example of that is the 12-lead ECG, which again may be a slight change to how we practiced in the past. The patients with the renal insufficiency are our patients that are at highest risk for developing hyperkalemia and should be in the back of your mind at this point moving forward to be considering this.
So we've just had another question roll in. And so this question asks, will sodium bicarbonate still have a place in our practice after the new directive is introduced? So this is a great question. As sort of we discussed earlier, there's sort of the risk benefit of sodium bicarb. So sodium bicarb will not be one of the primary therapies for hyperkalemia. As we mentioned here, the calcium sort of is most important, and then sort of use of Ventolin or the salbutamol. And that's really just because sodium bicarb doesn't actually lower potassium that well, and it takes a long time to work. So not really a great drug in the pre-hospital setting, and also can have the complications that we discussed. Now, sodium bicarb will still be available and can still be considered in special circumstances. So if there was a prolonged extrication, but that would be sort of a different and specific patch to a BHP. Again, sodium bicarb will not be part of the hyperkalemia medical directive.
So is that kind of new, Nat? I think that I read a study just not very long ago that showed that, like, traditionally paramedics are always thinking sodium bicarb for hyperkalemia, but that's fairly recent change, or?
I'm not sure how new it is, but change is sort of slow. I know that certainly even when I started med school 8 years ago, that was part of my initial algorithm. Like, what do you think if you see a patient with hyperkalemia, and it was drilled in that you give calcium and you give insulin and glucose and you give an amp of bicarb. But since then, I think slowly but surely the evidence has come out actually for a lot of those things, and saying, like, how quickly is this working? How well is it working? How much is it lowering the potassium? And with bicarb in particular, it's not working very quickly. It's not very good at lowering potassium, and sometimes it can actually do more harm than good. So rather than it being a part of sort of that general approach, now I think we're just sort of saving it and considering it for sort of very special circumstances, such as the patient with a severe metabolic acidosis, where it might be more useful. So I think with a lot of things in medicine that sometimes we just don't have a lot of literature. And then once that literature starts to come out, it takes a long time for people to sort of adapt to it, and then to not just do the gut reaction thing, as I said, like, oh, that's part of, my intuitive package and I'm going to give it to everybody. So we're rethinking things a lot more now.
Well, that's very good, because that's what we've always traditionally been taught, and I think that's why paramedics are automatically thinking that way. It's good.
Yeah,
Thank you, Nat.
Dogma in medicine takes a long time to change.
Oh, well.
Okay, so we've got another question here that just came in, asking if Lasix is returning. I'm assuming that this is coming because we mentioned that was sort of one of our pre-hospital strategies. Again, in terms of what's important to do pre-hospital and to stabilize the patient and get them to hospital, Lasix unfortunately takes many, many hours to work. And on some of these patients, you need to have reasonably functioning kidneys for Lasix to actually work. Because if your kidneys don't work, Lasix isn't going to help you excrete that potassium. So it sort of comes back to priorities in terms of timing. In the pre-hospital setting, we want things that are going to work sort of in the order of minutes to a half hour, an hour. And those are the treatments that we're going to have you guys administering. Again, Lasix isn't going to work for everybody. It takes a really long time to work. So just doesn't make as much sense, given that you guys have a limited amount of time on the field. We really want to focus on sort of getting those initial stabilizing treatments in and getting the patients to the hospital as quickly as possible.
So some services continue to carry Lasix, and typically we're not seeing actually a lot of orders given in the field for Lasix, but typically if we do, it's for CHF, and it's usually a paramedic specifically asking for it. So Lasix isn't returning. It's still there, but not in any of our directives, and we certainly probably wouldn't be getting an order for it for the hyperkalemia patient. Correct?
Correct.
Great. If we have any more questions, we'll stay on the line here for a few more minutes and answer any other questions.
We're not seeing any come in, and that's okay. So again, this is a medical directive that you're going to be seeing in the fall. We did not dive too deep into the medical directive today, just because we wanted to kind of just throw hyperkalemia out there, first of all, as something to start considering. And then we're very much looking forward to having some great interaction during the research this year, lots of questions. And if you have any questions prior to the research or in between at all, you can call one of your regional paramedic educators or patient care specialists. They're listed on the screen in front of you there. And we'll do our best to answer any questions you have. And we look forward to seeing you at this year's research. Thank you.
Well, seeing no hands up on the screen to ask any questions, and not seeing any other questions coming in through the door here, we will close this off. And I want to say thanks to Christine and Nat for putting this webinar together, and thanks for attending.
Thank you.